That measure has 2 votes, and we will keep.
Thank you, Madam Chair, members.
Thank you all very much. Senator Pan has been sitting patiently, so I'm going to use my chair's prerogative. Unless he's enjoying the scenery, we'll go ahead. And I don't think this is too lengthy a matter. So thank you, Senator Hernandez, for indulging us. Senator Pan, this is file item 17, SB 1353. Good afternoon, Senator.
Good afternoon, and thank you, Madam Chair, members. SB 1353 requires CalPERS and CalSTRS to hold a public board meeting and to take a public vote prior to overturning a statutory prohibition from investing in Sudan or thermal coal. This bill merely adds a similar procedural requirement that already exists in reinvesting in statutorily prohibited investments in Iran. Existing law prohibits CalSTRS and CalPERS from investing in companies with active business operations in Sudan, thermal coal, and Iran. However, the Constitution and applicable statutes allow a public retirement system to invest in prohibited investments if the retirement board finds that not doing so would violate its standard of fiduciary care and loyalty to its members. SB 1353 ensures that the CalPERS board provide timely notice to the public and the legislature of its intention to reinvest in such statutorily prohibited investments. I respectfully ask for an aye vote.
Very succinct. Any witnesses in support? Witnesses in opposition? Discussion? Senator Wojtkowski.
We've lifted the sanctions on Iran. We've entered into a nuclear agreement. We've normalized things. Other than the fiduciary responsibility, is there anything that triggers the board to consider this is no longer sanctionable, or does the legislature have to take an action on that?
Well, it was the legislature that took action on these 3 particular items. So what this bill says is that if they're going to reinvest, that the board would take action, fiduciary responsibility. However, since the legislature put them in, perhaps it's the legislature that would need to remove them. But again, if there's a fiduciary issue, then of course the board can act on its own. There are actually other areas where actually the board had acted on itself, which is not being covered by this bill, because again, it's not a legislatively passed prohibition.
It's also my understanding this bill refers to the Sudan and thermal coal, isn't
Correct,
it?
yes.
Yeah, those 2 very specific prohibitions.
In fact, we don't modify the Iran one at all.
That's the basis of the question, is that the federal government has taken action with regard to our relationship with Iran. We do have a prohibition there. I don't know if an investment comes available that would be, the board would think that they would like to invest in there to protect their fiduciary responsibility to get a return. Apparently they'd have to come back here to ask for that permission.
Well, actually, if it's a fiduciary issue, they can decide on their own.
Based on this legislation.
Yes. Well, existence.
Senator Pan, any questions? No. All right, Senator Pan, do you wish to close?
I respectfully ask for an aye vote. Thank you.
Very good. Do we have a motion? So moved. Moved by Senator Wojtkowski. The motion is due pass to Senate Appropriations. Please call the roll.
Jackson?
Aye.
Jackson, aye. Morlock? Morlock, no. Anderson? Hertzberg? Hertzberg, aye. Leno? Monning? Wojtkowski?
Aye.
Wojtkowski, aye.
That's bill has 3 votes, and we'll put it on call. Thank you very much. Senator Hernandez, come on down. File item 9, SB 1159. Good afternoon, and welcome to the committee. I don't think we see you too often, but it's a pleasure to have you here.
No, I think this is actually probably the first time.
Really?
This year. I don't know if I was here. Was I here last year?
Except for last year when we heard this bill.
Okay, well, then I guess I was here last year.
I was reminded. Thank you. Welcome, Senator.
Thank you, Madam Chair, members. So, you know, when I was appointed chair of the Senate Health Committee, there was 3 things that are of the highest importance to me. Number 1 is the successful implementation of the Affordable Care Act. The second thing is access to every person in the state of California, which includes the most vulnerable. But there's also an element that's just as important, and that's controlling costs, healthcare costs in our healthcare system. Everything I've done within the Health Committee with that in mind is to make sure that the consumer has the absolute best price. I don't believe in rate regs because I believe that the natural market has to play itself out. But I also realize, though, that transparency, especially in our healthcare costs, help control those costs. And it does this by several ways. It allows not only the purchaser, but it allows the insurance industry, but it allows government to kind of see where costs are and where the cost drivers are. So if we see, for example, like for a hip replacement is costing a lot more in a particular area compared to another, but yet the outcomes are the same, then we can question that, and then that'll drive costs to be more competitive. So I've been working on this bill for quite a few years. We've been having some hearings on cost containment, and this has always come up with what's called an all-payers database, but we've never been able to really figure out where we're going to house it, so we've been kind of working it along throughout the years, but this bill would require the report of cost and quality information so that when fully implemented, this information will be put into the hands of consumers so that they can understand their financial liability, can make informed decisions about health care coverage and health care. So with that, members, I respectfully ask for an aye vote. I have individuals here who like to speak in support of the bill.
Thank you very much. Good afternoon.
Good afternoon, Madam Chair. We were pleased, Beth Capel on behalf of Health Access California. We well remember the discussion in this committee last year and appreciate working with your staff on amendments to protect the privacy of consumers, which we also value. This is an important measure in moving forward on what we call the quadruple aim of lowering costs, improving health outcomes, improving the healthcare system, and reducing health disparities. This bill, if enacted, would actually put California at the forefront of doing those things. Right now, we are lagging behind other states, I'm sorry to say, in terms of doing that. This bill would also do something that no other state has yet accomplished, which is to include our managed care plans with their capitated payments. That's a very important element of this bill, given the dominance of managed care in the California healthcare market. Other databases are claims databases, and of course only a small fraction of California's insurance market is insurance rather than managed care plans. So for these reasons, we're very pleased to be here in support of this bill and continuing to work with the author. Thank you.
Thank you. Other witnesses in support?
Kimberly Chen with the California Pan-Ethnic Health Network in support.
Thank you very much. Others in support?
Madam Chair, members, Sarah Flocks from the California Labor Federation. We have some tweaks that we are asked for to this bill, but we have been working with the author. We very much support all of his work on transparency and would like to see this bill move forward. Look forward to working on it. Thank you.
Thank you.
Stuart Ferry with the National Multiple Sclerosis Society in strong support.
Thank you, sir.
Renee Bayardo, SEIU, California, also in support.
Thank you. Any other witnesses in support? Witnesses in opposition? Good afternoon.
Afternoon. Aaron Lewis for the Consumer Federation of California. We have an opposed unless amended position. We strongly support the object of this bill. It's transparency in healthcare costs is incredibly valuable for consumers. Very supportive of that. However, we do believe that there still is some work to be done with regard to protecting privacy. And we look forward to working with the Senator's staff in terms of addressing some of these concerns. However, we do not believe that the protections of California's Confidentiality of Medical Information Act necessarily apply. This database would not be considered a provider under that statute. And we do note in the analysis that even if that were not the case, the Information Practices Act would apply. However, just one example, CMIA's definition of medical information is much more expansive and comprehensive than the Information Practices Act, which does talk about medical history. However, CMIA's definition of medical information does contemplate situations where medical information could be re-identified by using public information. So we also would be in support of explicit requirements for encryption and other elements. But as I mentioned, we are very supportive of this bill's objective and look forward to working with the author staff.
Thank you.
Thank you.
Becca Kramer, ACLU of California, also in opposition unless the bill is amended. We too share the concerns about needing to ensure that CMI protections are extended to the database. Additionally, we note that the bill prohibits private disclosing of public disclosing of unaggregated individually identifiable information, but does not prohibit private disclosure of such unaggregated, personally identifiable information. And it was a simple amendment to just strike out the word private to make sure that unaggregated, personally identifiable information cannot be shared publicly or privately. Additionally, as you all are aware, if you've paid attention to the news at all, encryption is really important, especially in this day and age where data breaches are not a matter of if, but a matter of when. And so we respectfully request that this database be encrypted to ensure that it was protected further against data breach and that the confidentiality of this information is further protected. Additionally, because data breaches are so common, it's important that this statute also explicitly reference the data breach notification and remedies and say that they apply to this database as well. And so those are our concerns.
Thank you very much. Other witnesses in opposition? Seeing none, take it back to the committee. Senator Hernandez, I have a couple questions. One is also the whole issue of privacy. That's one of the key elements of this committee's work. But before I get to that, as I read the bill, I note that it excludes providing the public about costs, the internal costs that go on. Did I misread that, or is there, let me see if I can find it. They're prohibited, let's see. Hold on one second. Let me have that. Specifically on my now torn copy of the bill. Under it's at page 5, starting line 16, confidentiality negotiated contract terms contained in a contract between a healthcare service plan or insurer and a provider or supplier shall be protected in any public disclosure of data made pursuant to this section. Again, that's information as to the costs, and I know we want to get that out there because costs are part of one of the challenges that we're facing with this healthcare system. Yes.
Beth Capel on behalf of Health Access California again. One of the challenges that we face in the healthcare system is that since 1982 in California, the way we have controlled cost is through confidential negotiations between plans and providers, and that information is not made public. Senator Hernandez has carried a series of bills to make sure that the consumers who are enrollees of a specific health plan can get information about their costs. And so this paragraph needs to be seen in the context of those other measures, most of which, as I recall, are now law. And so making public the negotiated contract rates is something that Governor Brown stopped in 1982, and so we suspect would have, this is the way our healthcare system works, is proprietary negotiations.
Would it likely reduce the cost of healthcare? Were we able to find out what these costs are to shed some sunshine onto this? I mean, again, the costs are substantial and they continue to increase. Would this be something that would be helpful to contain the costs? I won't say reduce them, but at least better contain them.
You know, I think it's a conversation to be had. I don't know if in the near future, but let me give you examples of how the healthcare system worked in the past and how we're making that transition and how it can change. So in the past, when you had Pre-Affordable Care Act and somebody had a pre-existing condition, you had no leverage whatsoever. You were out by yourself. So somebody like CalPERS, who is a large purchaser, could negotiate because they had a lot more buying power, and they negotiated in good faith, but their contract and their negotiations were proprietary, and the information was out. The market's starting to change. Now you have Covered California has large numbers, and it may get to that point, but I think it's because where we're at now, I would question if the timing's correct. And I don't know, maybe Ms. Capel can add upon that as well, but just the nature of how healthcare has been and how we've purchased it in the past, and it's an ever-going evolution right now.
I would just note that Covered California is currently, their new contract would require that the costs be made available to their enrollees from their health plan, and that has been resisted by both the health plans, the doctors, and the hospitals. So it's an important area that you raise, but it's
Political hot potato.
yeah.
Okay, thank you. I appreciate it. And so let me get to the question that I think is of greatest concern to this committee, the privacy issue, the encryption, the other suggested ways to try to address the potential identification of individuals with this program, and if you could address that, because I think that's really a grave concern.
Yeah, and I agree. I think it is a grave concern, especially if you look at, Target and the various banks and, the hacking, and nobody wants their information out. But nobody especially wants health information out where, blood pressure, pre-existing conditions. I understand that. But what we also have to make sure is that we have the ability to see data and to need to be able to analyze it through various entities, but how do we balance that privacy with the patient, but at the same time analyze the data to find out where the cost drivers are, but more importantly, what are the outcomes of it? So, last time we were going to take, obviously, the lead of the committee to look at the privacy of the individual, and obviously we want to look to again, and I don't know, maybe Ms. Capel can kind of chime in, but the most important thing is getting the data, aggregating it, and be able to analyze it.
So to my last question then, Senator Wieckowski. So as we look at the desire to deal with the cost drivers and outcomes, and that's why cost drivers, one of the cost drivers is something that we aren't privy to because for what we were just talking about. But assuming that we can, to some extent, identify cost drivers and then also outcomes, which is critically important. How do we do that, and do you have any suggestions, or in addition to the ones that you had suggested earlier, to protect those privacy rights of the individuals? Can you speak to that and also indicate where you think there might be success in negotiating that part of this bill, so that as it moves forward, if it does, that we are responding to those privacy concerns that I think are critical?
Well, I think just one main important factor here, just given that tens of millions of records will be collected, and records of the most sensitive information arguably out there, explicit language, specificity, and certainty, I think, is important, just ensuring that the authorization procedures within California's medical privacy laws are in place. And I do believe that there can be a balance achieved, certainly, but I think given the sensitivity and the scale of the collection, I think that certainty and specificity within the bill and the language is probably paramount.
Well, I know that Senator Hernandez is concerned about this, just articulated as well. Senator, are these negotiations going on? Do you feel as though at the end of the day we'll be able to get explicit enough language, specificity, and certainty? Are these goals as well for this bill?
Well, keep in mind, I think this is going on my third year, maybe even fourth year, where we actually started to figure out how we control costs, how we went down this route. We've either run into problems with appropriations, where it's going to be housed, whether it's public, private, whether it's governmental entity. We've been dealing with these issues. Yeah, it's an ongoing, and I understand the concerns, and I don't want to have somebody's health records out in cyberspace either. But I'm always willing to figure out how we achieve that. And I've got 2 years left. If I don't get it this year, we got at least 2 more years to try to figure out how. And we all agree that at the end goal is to control healthcare costs and bring them down.
So why is encryption not?
I mean, encryption, I don't see it being a problem just so long as it can be analyzed properly, and maybe at the receiving end, that person, the entity that's responsible for decrypting it, has the authority to do it, but it also has the authority and the ability to analyze the data.
So if I might, Madam Chair, Beth Capel, Health Access. So when you're thinking about costs, you're thinking about what's the price for the hospital stay. When we're thinking about costs in this database, we're thinking about the reality that someone with a feeding tube is twice as risky as someone with HIV or brain cancer, and that's where the costs are in the healthcare system. So you don't have to have a lot of those folks. But you need to know, is this an individual? And this is part of what makes the privacy piece so important, but at the same time, we're trying to balance here so that entities can actually use the data in a useful way. So what's usually going on is somebody who's pretty sick has a number of things going on. And then we also want to look at it in the context of disparities. We have a disproportionate number of people of color who have diabetes, hypertension, and all that. So we want to, as we deal with encryption, make sure that we're not depriving the data of the very richness that allows us to use it in smart ways in order to get to what we all agree are the aims. And so we'd just like to have the opportunity to have a little more conversation before we inadvertently agree to something that makes the database meaningless.
And I look forward to your continuing to do that and appreciate your willingness to continue. Motion by Senator Hertzberg. Senator Wojciechowski, you had to.
Yeah. I was just going to. My follow-up question is on security and the encryption, because the staff report points out that the current law requires a governmental agency to use reasonable administrative, technical, and physical safeguards to protect information. We know with the Uber situation, there's encrypted information that gets stolen with the key. So it makes you a little bit nervous, although I'm hearing the author and advocates about the data. And that's beyond this hearing, what we need to do. But we do have a challenge to use the best safety measures under current law. You just remind everybody of that.
Thank you. Senator Morlock.
Thank you, Senator Hernandez, at the County of Orange, we had a self-insured PPO, and so we kind of knew every year where we had the data, and so we could kind of see where our issues were, out-of-network problems, the rest. So I'm just sort of curious, your vision of where is all this data coming from? Is it coming from PPOs? Is it coming from
all
MCOs?
Payers,
or is it coming from practitioners like yourself, where you got to fill forms in and provide?
So I would probably, where most of it come from is what are called ICD-9 codes, which are diagnosis codes, and also billing codes. And if you think about health plans, when they process the claims,
okay,
they have a lot of data that shows payments out. Another example is what the federal government did in, I believe, the late 80s, early 90s, when they were trying to control their costs, and they found out that there were certain areas of excessive billing, which was in cataract surgery and I believe in cardiology, that the Medicare system was paying these ungodly numbers of dollars out to payers or to providers. So they scaled back the reimbursement based on the risk, based on the outcomes, and they started to save some more money. But they were only able to do that by looking at the data. So you have a lot of information that's out there. It just, we don't have the ability to analyze it because we don't have access to it. So health insurance companies have all of it. Covering California is going to have all of that information.
So then, is it a state requirement, or should just the Affordable Care Act take care of it, and let the federal government?
Well, it's not. It wasn't explicit in the Affordable Care Act. You made a comment about your health system. Well, you have an enclosed system that you can analyze your own data to control costs. Well, now you've got, all the health plans. You've got Cover California. You've got Medi-Cal. You've got Medicare. But you have all this data out there, but where are the cost drivers and what's the cost of healthcare? If we gather all that data and analyze it, we can figure out, okay, so why is it that we're spending more money in Northern California than Southern California? Why, we can start looking and analyzing data to control cost.
Wouldn't that be more of an industry issue? How do we get cost savings? How do we benefit from that so that at the end of the day, we're providing a service that is cost neutral?
What do you mean as far as an industry?
Well, we're gathering all this information. We're not an MCO, right? So how do you use that data?
Well, I mean, you use it through public transparency. You don't spell out, for example, a patient's name, but you can say that cost has gone up by X percentage in California in these areas, which seem excessive, but yet you have providers providing the same amount of the same procedure at a lower cost, and it's more better outcomes.
So you're shaming somebody.
That's what transparency essentially is. Yeah. Like I said, I'm not a proponent of cost control. I don't think we should regulate the market, but at the same time, we are now mandating that everybody purchase health insurance. It's incumbent upon us to make sure that we have. The hard reality of healthcare is we're going to have to see more patients at a lower price point, and we're going to have to keep people healthier, and we're going to have better outcomes. But the only way we're going to know that is through transparency. The next step is a regulated system where you have a PUC-style, entity that says, look, drug companies, you can't charge this much. Hospitals, you can only charge this much. I still believe in the free entrepreneurial system, but the next best thing that we need to do is look at where are all the costs at.
Thank you. Thank you, Madam Chair.
So that means you're going to vote for the bill, right?
We'll accept that as your close, Senator Hernandez. Good try there. We'll find out. Do we have a motion? Hertzberg, a motion by Senator Hertzberg.
Like Senator what? Hertzberg?
Hertzberg.
Hertzberg.
All right, the motion is due pass to Senate Appropriations. Please call the roll.
Jackson?
Aye.
Jackson, aye. Morlock? Anderson? No. Anderson? Morlock? Morlock, no. Anderson, no. Hertzberg? Hertzberg, aye. Leno? Monning? Wachowski?
Aye.
Wachowski, aye.
Thank you very much, Senator Morlock.
Has 3 votes. You need 1 more vote, so we'll put it on call, 3-2. Next up, the only non-member of the committee left is Senator Mendoza, who is not here. So, Senator Hertzberg, if you'd like to go ahead.